Hi, nursing family. Curious about what NCLEX might ask you when it comes to pediatric eye and ear medications? You are in the right place. In today's video, Pharmacology in Child Health, Visual and Auditory Systems, we are going to cover key drugs used for common pediatric eye and ear conditions, like conjunctivitis, otitis media, and post-surgical care. You will learn how these medications work, why they are prescribed, and what NCLEX loves to ask about them. We bring you important NCLEX topics and practice questions every single day, so be sure to watch the full video and follow us regularly to stay ahead in your NCLEX prep. Let's take a quick moment before we begin. Are you confident about passing the NCLEX? If not, don't worry. The complete NCLEX Review online course gives you 100 hours of animations, 500 hours of recorded lectures, 5,000 practice questions, 500 NGN-style case studies, and 15 mock exams just like the real test. You'll also get an ebook and 1 year of full access. Enroll now and get 70% off, only for a short time. Head to the link in the description and start your success journey. Here comes your very first high-yield NCLEX question. Question number 1. While assessing a 10-month-old infant who presents with persistent ear tugging, low-grade fever, and increased fussiness, the nurse suspects acute otitis media. Which of the following anatomical or developmental features most significantly increases the infant's susceptibility to this condition when compared to adults? Now, let us walk through each of the answer choices carefully and see which one makes the most clinical sense. Option A, lack of cervical lymphatic development. Option B, underdeveloped external auditory canal. Option C, frequent hand-to-mouth activity. Option D, narrower, shorter, and more horizontal eustachian tubes. Now here is where we critically think through the correct answer. The correct response is option D, narrower, shorter, and more horizontal eustachian tubes. Let us talk about why this matters so much in infant care and why it is crucial for NCLEX preparation. In a 10-month-old infant, the eustachian tubes have a distinct structural disadvantage compared to those in older children or adults. These tubes measure only about 18 millimeters and lie nearly horizontal, at roughly a 10-degree angle, making it easy for secretions from the nasopharynx to travel up into the middle ear. Because of their narrow diameter, they are also more likely to become blocked from inflammation or congestion during a cold or allergy episode. The lack of vertical tilt and shorter length prevents normal drainage and ventilation of the middle ear, leading to negative pressure and fluid retention. That warm, moist environment becomes a breeding ground for bacteria and viruses, leading to acute otitis media. These anatomical characteristics are also why bottle feeding in a lying position increases risk. Gravity no longer helps drainage, and reflux of fluids into the middle ear becomes more likely. Understanding the structural predisposition is key not only to answering NCLEX questions, but also to recognizing how feeding position, age, and respiratory health can influence infection risk in real-life pediatric nursing. Now, let us break down why the other options do not hold up. Starting with option A, although the lymphatic system is not fully mature in infants, a lack of cervical lymphatic development is not the driving factor behind otitis media. Enlarged lymph nodes may be present in response to infection, but they are not the cause. This distractor option might sound immunologically relevant, but the issue here is primarily mechanical, not immune. Looking at option B, the external auditory canal refers to the outer ear, which does not play a role in middle ear infections. Otitis media involves inflammation and infection behind the tympanic membrane in the middle ear, not the external canal. This is a classic example of why knowing anatomical boundaries is essential for test questions and clinical reasoning. Finally, option C mentions frequent hand-to-mouth activity, which is indeed common in infants and increases their exposure to germs. However, exposure alone does not equal infection. The reason infants get otitis media more often is not just because they encounter pathogens, but because their anatomy allows those pathogens to travel easily into the middle ear. That is why understanding structural vulnerability, especially the eustachian tube's orientation, is a key takeaway for this concept. Jumping straight into our next NCLEX scenario, question number 2. A 1-year-old infant is brought to the emergency department with signs of acute otitis media, including a persistent fever for over 24 hours, inconsolable crying, and repeated tugging at the left ear. Upon assessment, the child is irritable, febrile at 102.6 degrees Fahrenheit, and holding the left side of the head. Which nursing intervention should the nurse prioritize to provide immediate therapeutic relief? Let us carefully examine each of the options one by one. Option A, elevate the head of the crib to reduce inner ear pressure. Option B, administer acetaminophen as prescribed. Option C, teach the parents about tympanostomy tube placement. Option D, irrigate the external ear canal with warm saline. Now moving forward to identify the correct response and fully understand the clinical reasoning behind it. The right answer is option B, administer acetaminophen as prescribed. In this situation, the child is in acute distress with a high fever, systemic discomfort, and significant irritability, hallmarks of a painful and possibly advanced middle ear infection. The nurse's priority here is to manage the fever and alleviate discomfort. Acetaminophen, dosed according to the child's weight, serves as both an antipyretic and analgesic. It not only helps bring the fever down, but also relieves the atalgia, or ear pain, that is causing the infant to cry inconsolably. Reducing the fever is also essential in this age group because it minimizes the risk of febrile seizures, which are more common in children under the age of 5. This pharmacologic intervention provides rapid relief and stabilizes the child's condition, allowing for further assessment and supportive care once the acute distress is addressed. Now, turning to option A, elevating the head of the crib may help reduce ear pressure by promoting drainage from the eustachian tube, but it does not provide immediate pain or fever relief. It can be used as a supportive measure later on, but it is not the priority in an actively febrile, irritable infant. Now, let us look at option C, which involves teaching the parents about tympanostomy tube placement. While this is appropriate for children with recurrent or chronic otitis media, it is not suitable during an acute episode. At this stage, the focus should be on symptom control and managing the current infection, not on surgical education or long-term planning. Finally, option D, irrigating the external ear canal, is completely inappropriate in this scenario. Otitis media is a middle ear condition, and irrigation can actually worsen symptoms, increase pain, or even cause trauma if the tympanic membrane is inflamed or ruptured. This intervention is typically used only for cerumen impaction and has no therapeutic benefit in a febrile child with acute otitis media. For NCLEX success, always prioritize actions that directly relieve the patient's most critical symptoms, and in a 1-year-old with high fever and distress, antipyretic medication is your first step toward stabilization. Let's walk through another key topic, and this one puts your pediatric observation skills to the test. Question number 3. A 5-year-old child is brought to the primary care clinic with complaints of right eye discomfort. The caregiver reports frequent eye rubbing, and the nurse notes watery discharge, mild conjunctival erythema, and occasional crusting. Based on these findings, which condition is the child most likely developing? Let us break down each of the answer choices to uncover the most accurate diagnosis. Option A, conjunctivitis. Option B, retinopathy. Option C, glaucoma. Option D, ptosis. Now zeroing in on the correct choice and expanding on the reasoning behind it, the correct answer is option A, conjunctivitis. This child's symptoms, watery discharge, itching, eyelid crusting, and mild redness, are textbook indicators of conjunctivitis, which is an inflammation of the conjunctiva caused by viral, bacterial, or allergic triggers. In viral cases, which are very common in children, the discharge is usually watery, and symptoms often follow an upper respiratory infection. In allergic conjunctivitis, itchiness is dominant, and the condition often affects both eyes. Bacterial conjunctivitis, on the other hand, may involve thicker yellow or green discharge and is more likely to require antibiotic eye drops. Regardless of cause, prompt recognition is crucial to reduce discomfort, prevent transmission, and initiate appropriate treatment. Since conjunctivitis is highly contagious, especially in school-age children, nurses must be able to quickly identify these signs and provide both medical and educational support to the family. Now, turning to option B, retinopathy is a retinal disorder that usually affects vision due to vascular or structural damage. Common examples include diabetic retinopathy or retinopathy of prematurity. These are internal eye conditions that do not present with crusting, external discharge, or visible redness, and are typically diagnosed via retinal imaging, not clinical observation alone. Moving on to option C, glaucoma in children is rare and presents differently. When it does occur, it usually causes photophobia, tearing, and sometimes an enlarged or hazy cornea due to elevated intraocular pressure. This is not the same as crusting or conjunctival irritation, and diagnosis requires specialized equipment like tonometry, which is not part of routine outpatient nursing assessment. Lastly, option D, ptosis refers to drooping of the upper eyelid, most often from muscle weakness or nerve dysfunction. It might obscure vision but does not cause discomfort, redness, or discharge. It is a physical observation with no inflammatory or infectious component. So for NCLEX success, remember to link external symptoms, such as discharge and redness, to surface-level conditions like conjunctivitis, and distinguish them from deeper or structural disorders that do not present externally. Next up on your NCLEX prep journey, question number 4. During a routine preschool vision screening, a nurse evaluates a 4-year-old whose parent reports that one of the child's eyes drifts to the side in family photos. To assess ocular alignment, the nurse performs the corneal light reflex test. Which of the following findings most strongly suggests strabismus? Let us go ahead and consider each of the answer options thoughtfully. Option A, delayed pupillary constriction to light. Option B, asymmetrical reflection of light on the corneas. Option C, presence of vertical gaze, palsy. Option D, positive red reflex in both eyes. Now turning our focus to the correct answer, the right choice is option B, asymmetrical reflection of light on the corneas. This finding is a key indicator of strabismus, a condition in which the eyes are misaligned and do not track together. During the corneal light reflex test, also known as the Hirschberg test, a light is shined toward the child's eyes from about 12 inches away while the child looks straight ahead. In a child with normal alignment, the light reflection appears symmetrically in the center of both corneas. However, when one eye is deviated due to strabismus, the reflection appears in a different location on that eye's cornea, clearly signaling a misalignment. This test is especially useful for preschool-aged children who may not yet be able to perform accurate visual acuity testing. Early identification is absolutely essential because untreated strabismus can lead to amblyopia, or lazy eye, where the brain begins to suppress input from the weaker eye, potentially causing irreversible vision loss. Prompt recognition and referral are vital to prevent this outcome. Now, let us break down the incorrect choices. Starting with option A, delayed pupillary constriction to light may point to neurological concerns or possible drug exposure, but it is not an assessment tool for detecting eye misalignment. It assesses the pupil's reactivity, not alignment, and would not help confirm strabismus. Moving on to option C, vertical gaze palsy is a sign of neurological dysfunction, particularly midbrain pathology, and is not typically assessed in routine pediatric vision screenings. It presents as difficulty moving the eyes up or down and is unrelated to corneal light reflex asymmetry. Lastly, option D, a positive red reflex in both eyes, is a reassuring finding during ocular exams. It helps rule out serious issues such as retinoblastoma or congenital cataracts, but it tells us nothing about eye alignment. A child can have a perfectly normal red reflex and still have strabismus. So for NCLEX purposes, when you are looking for signs of misalignment, focus on the corneal light reflex and how symmetrical it appears across both eyes, because that is where early sight-saving clues begin. Let us shift gears into an emergency school setting where quick judgment matters. Question number 5. A 6-year-old child is brought to the school nurse after a wood chip flew into the right eye while playing outdoors. The child is tearful, shielding the eye, and unable to fully open it due to discomfort. There is no visible foreign body on the external surface. What is the nurse's most appropriate initial action? Take a moment to consider the clinical weight of each of these options. Option A, encourage the child to keep the eye closed until the parent arrives. Option B, apply a mild anesthetic eye drop to relieve discomfort. Option C, assess the child's visual acuity in both eyes. Option D, attempt to gently flush the eye with lukewarm milk. Now moving into the best clinical decision, the correct answer is option C. Assess the child's visual acuity in both eyes. This is the very first and most appropriate step in managing any suspected eye injury. It provides a vital baseline for comparison and helps guide the urgency and direction of care. Whether or not the object is visible, assessing visual acuity helps determine whether the eye's internal structures are compromised. Importantly, This test must be done before any further manipulation of the eye, such as irrigation or patching, because interventions can temporarily affect vision, making post-treatment assessments less accurate. In young children, visual acuity should be evaluated using age-appropriate tools like LIA symbols, picture charts, or even simple object tracking if the child cannot verbalize responses. Documentation of these results is essential for communicating findings to the next provider and supporting timely referral if needed. Now let us examine why the other options are not the best initial steps. Looking at option A, while keeping the eye closed may provide some comfort, this action delays proper assessment. Waiting for a parent postpones medical care, and in any eye injury, time is critical to preserve vision. Next is option B, applying a mild anesthetic eye drop. This might seem tempting for pain relief, but it is not within the nurse's scope without provider orders and can be very risky. These drops can mask important symptoms, like corneal abrasions or globe rupture, and may delay or misdirect treatment. Improper use of anesthetics in eye injuries has been linked to poor healing and long-term corneal damage. Finally, option D, flushing the eye with lukewarm milk, is not only inappropriate but also potentially dangerous. Non-sterile substances like milk can introduce bacteria into the eye, raising the risk for infection. If irrigation is required, it should only be performed with sterile normal saline or sterile water, and only after ruling out penetrating injury. For NCLEX, always remember, your first step in ocular trauma, unless dealing with a chemical exposure, is to assess visual acuity. This protects both the patient and the nurse by setting a clinical baseline before any treatment is introduced. Now let us turn our focus to medication administration in pediatric eye care, an area where both safety and technique make all the difference. Question number 6. A nurse is preparing to administer erythromycin ophthalmic ointment to a 3-year-old child diagnosed with bacterial conjunctivitis. The caregiver asks, "Where exactly should I apply the medicine?" Which of the following is the most appropriate action by the nurse to ensure both safety and therapeutic effectiveness during administration? Let us walk through each of the options carefully and identify which practice aligns with correct clinical technique. Option A. It is best to instruct the child to close their eyes tightly while you apply the medication. Option B. You should place a thin ribbon of ointment into the lower conjunctival sac, not directly on the eye. Option C. The ointment should be rubbed across the eyelid after it is applied. Option D. You should apply a line of ointment directly across the cornea to ensure full contact with the infection. Now, highlighting the most correct and safest practice, the best answer is option B. You should place a thin ribbon of ointment into the lower conjunctival sac, not directly on the eye. This method is widely accepted in both pediatric and adult eye care because it ensures optimal drug absorption while minimizing harm. The lower conjunctival sac is the natural pocket formed when you gently pull down the lower eyelid, and placing the medication there allows the ointment to spread naturally across the eye surface through blinking. This also helps avoid direct contact with the sensitive cornea, which can be easily irritated or damaged. Educating caregivers on this method not only supports proper treatment, but also reduces anxiety and promotes adherence during home care. Importantly, nurses must always emphasize that the applicator tip should never touch the eye or lashes to avoid contamination or injury. Now reviewing the incorrect techniques, option A, instructing the child to close their eyes tightly during administration may cause the ointment to be squeezed out, reducing effectiveness and increasing the child's distress. It can also make future administrations more difficult due to fear or resistance. Encouraging the child to look upward instead is much more effective. Turning to option C, rubbing the eyelid to spread the medication is not recommended. This can introduce new bacteria from the hands or skin, increase the risk of reinfection, and potentially remove or displace the medication. Blinking alone is typically enough to spread the ointment evenly. Lastly, option D, applying ointment directly across the cornea, should be strictly avoided. This can trigger intense discomfort, cause the child to blink or pull away, and even risk mechanical injury to the cornea. For NCLEX success and clinical safety, always remember that medication should go into the lower conjunctival sac, not on the cornea or eyelid, and that teaching caregivers correct technique is just as important as the treatment itself. Right before we get into the question, let me ask you this. Is your NCLEX prep complete? If not, the complete NCLEX review course gives you 100 hours of animations, 500 hours of lecture content, 5,000 high-yield questions, 500 NGN case studies, and 15 mock exams, all with a year-long ebook. Save 70% today, but the deal won't last. Click the description link to enroll and start strong. Here comes a question focused on antibiotic safety and parental teaching. Question number 7. The nurse is preparing discharge instructions for the parent of a 2-year-old recently diagnosed with acute otitis media and prescribed high-dose amoxicillin suspension. The parent asks, "Can I stop giving the medicine once the fever is gone?" Based on best practices for pediatric antibiotic use, which response should the nurse give? Let us go over each of the possible responses before choosing the best nursing reply. Option A. Store the medication in the cabinet at room temperature to preserve its effectiveness. Option B. Give a double dose if you accidentally miss one to keep the level strong. Option C. You can stop the antibiotic as soon as the child's fever and ear pain are gone. Option D. It is important to continue the full course of amoxicillin even if symptoms improve quickly. Now turning to the correct and most evidence-based response, the best answer is Option D. It is important to continue the full course of amoxicillin even if symptoms improve quickly. This is a foundational principle of pediatric antibiotic management and a key point for NCLEX success. Even though symptoms like fever and ear pain may resolve within the first 48 to 72 hours, this does not mean that the infection is fully eradicated. Incomplete courses of antibiotics increase the risk of resistant organisms, recurrent infections, and complications like mastoiditis or chronic otitis media. The nurse's role is to clearly educate caregivers that symptom relief does not equal infection clearance. The bacteria may still be present in the tissues and require the full course of medication to ensure complete resolution. This instruction not only promotes healing, but also reinforces principles of antimicrobial stewardship, which is critical in reducing community resistance. Now breaking down the incorrect responses. Option A. Storing the medication at room temperature is not advisable for most liquid amoxicillin suspensions. These usually require refrigeration to maintain their effectiveness. Storing it at room temperature can degrade the drug, reducing its therapeutic benefit. Always check the pharmacy label and reinforce that proper storage prevents underdosing and treatment failure. Option B recommends doubling the dose if one is missed, which is unsafe and incorrect. Doubling a dose in a small child can lead to adverse effects like gastrointestinal upset or even more serious toxic effects. The correct instruction is to give the missed dose as soon as it is remembered, unless it is almost time for the next dose, and never double up. This reinforces medication safety and avoids unintentional harm. Lastly, Option C, telling the caregiver to stop the medication once symptoms resolve, is a common misconception that leads to treatment failure and resistance. Children often feel better long before the bacteria are fully cleared. Reinforcing full completion of the antibiotic course is a nursing priority in discharge planning. So for NCLEX purposes, always select the option that emphasizes complete treatment, safe storage, accurate dosing, and patient education, especially when it comes to antibiotics in pediatric care. Next up is a question that dives into caregiver education and proper technique for administering otic medications at home. Question number 8. A 6-year-old child diagnosed with otitis externa is prescribed ciprofloxacin, dexamethasone, otic drops. The parent asks how to properly give the drops at home. Which instruction should the nurse include to ensure optimal delivery and comfort? Let us go through each of the choices to find out which one aligns with best clinical practice. Option A. Administer the drops after each bath to keep the canal moist and lubricated. Option B. Insert a cotton-tipped swab after administering drops to help spread the medication. Option C. Have the child lie down with the affected ear facing up and stay in that position for 5 to 10 minutes. Option D. Massage the outer ear after the drops are given to push the medication in deeply. Now selecting the best nursing response, the correct answer is Option C. Have the child lie down with the affected ear facing up and stay in that position for 5 to 10 minutes. This is the gold standard approach for otic medication administration. Positioning the child in this way allows gravity to distribute the drops throughout the ear canal evenly, helping the medication reach and coat the inflamed tissue. Holding the position for several minutes enhances absorption, reduces leakage, and increases overall effectiveness. This method also avoids unnecessary manipulation or trauma, which is especially important in a child with a painful ear infection. Caregivers should also be taught to gently warm the bottle in their hands before administration, to avoid dizziness or discomfort caused by cold drops. Teaching this technique clearly and calmly empowers families to administer treatment effectively at home. Now evaluating the incorrect responses, option A is not recommended. Applying ear drops after a bath increases moisture in an already inflamed ear canal, worsening the condition. Otitis externa, often called swimmer's ear, typically results from retained water and humidity in the ear canal. The focus should be on keeping the ear dry, not moist, during the healing process. Now, for option B, inserting a cotton-tipped swab is unsafe and should never be advised. Cotton swabs can damage the delicate epithelial lining of the ear canal, push infectious debris deeper, or even puncture the tympanic membrane. Caregivers should be explicitly warned against using swabs for any part of the inner ear. Turning to option D, massaging the outer ear may seem like a harmless technique, but it is unnecessary and may aggravate a tender, inflamed area. Pain or trauma from physical pressure can make the experience more distressing for the child and is unlikely to help medication distribution. For NCLEX success, remember that when it comes to otic drops, proper positioning and time, not pressure or added moisture, are the keys to safe and effective drug delivery. Let us now shift into pharmacologic eye treatments with question number 9. A 4-year-old child is undergoing an eye examination and is prescribed atropine ophthalmic drops to dilate the pupil and induce cycloplegia. Which potential side effect should the nurse include in the caregiver teaching as an expected and manageable outcome? Let us examine each option carefully before identifying the correct teaching point. Option A, excessive tearing and itching of the eyelids. Option B, photophobia and difficulty focusing on close objects. Option C, blurred peripheral vision and tunnel vision. Option D, severe eye pain and halos around lights. Now identifying the correct teaching point for this common pediatric medication, the best answer is option B, photophobia and difficulty focusing on close objects. Atropine is an anticholinergic agent that works by blocking the parasympathetic input to the eye, resulting in 2 key effects: mydriasis, which is dilation of the pupil, and cycloplegia, which is paralysis of the ciliary muscle responsible for accommodation or focusing on near objects. As a result, children may become sensitive to light and struggle with activities like reading or drawing. This is a normal and temporary side effect that typically resolves in a few days, although in some cases, especially in children, the effect may last up to 14 days. Nurses should reassure caregivers that this response is expected and suggest sunglasses or dim lighting to reduce discomfort while the drops are active. It is also important to remind them that children should avoid prolonged near-vision tasks during this period to prevent eye strain or frustration. Now reviewing the incorrect responses, option A, excessive tearing and itching of the eyelids, is not a typical response to atropine. These symptoms may suggest an allergic reaction or eye irritation beyond the normal scope of the drug's effect. While minor irritation is possible with any eye drop, persistent tearing or itchiness is not an expected outcome and should prompt follow-up evaluation. Turning to option C, blurred peripheral vision and tunnel vision are not consistent with atropine's mechanism of action. These symptoms could indicate serious retinal or optic nerve issues and are not expected with routine pupil dilation. This type of visual field change should always be treated as an urgent ophthalmologic concern. Lastly, option D, severe eye pain and halos around lights, could be signs of acute angle closure glaucoma, a rare but serious medical emergency. Although this complication is extremely uncommon in young children, any report of these symptoms should be taken seriously and requires immediate provider notification. For NCLEX, always recognize that photophobia and near-vision difficulty are common, manageable side effects of cycloplegic medications like atropine, while anything involving pain, peripheral vision changes, or allergic symptoms deserves further evaluation. Let us move into chronic eye conditions now, with question number 10. A 10-year-old child recently diagnosed with pediatric open-angle glaucoma has been prescribed timolol malate ophthalmic drops. The nurse provides education to the caregiver on what to expect from this treatment. Which clinical effect of timolol should the nurse emphasize as the primary mechanism of action? Let us now examine each answer, option one by one, and determine which reflects accurate pharmacologic action. Option A, local vasoconstriction to improve optic nerve perfusion. Option B, increase tear production to improve corneal hydration. Option C, decreased aqueous humor production to reduce intraocular pressure. Option D, relaxation of ciliary muscles to widen the angle of Schlemm's canal. The correct answer is option C, decrease aqueous humor production to reduce intraocular pressure. Here is why this mechanism matters and what makes it essential for effective treatment. Timolol is a non-selective beta-adrenergic blocker that works by inhibiting beta-1 and beta-2 receptors located in the ciliary epithelium of the eye. These receptors normally stimulate the production of aqueous humor, the fluid that maintains intraocular pressure by circulating through the anterior chamber and exiting through the trabecular meshwork. When timolol is applied topically, it reduces aqueous production at the source, lowering intraocular pressure and thereby reducing the risk of optic nerve damage, which is the primary concern in both adult and pediatric glaucoma. This pressure-lowering effect helps preserve visual fields and slows the progression of the disease, which is often asymptomatic in early stages. For NCLEX purposes, it is essential to know that the therapeutic goal in open-angle glaucoma is not to cure the disease, but to control the pressure long-term. Since timolol can be systemically absorbed even when applied topically, nurses must educate caregivers about punctal occlusion, applying gentle pressure to the inner corner of the eye after administration for at least 30 to 60 seconds, to prevent systemic side effects such as bradycardia, bronchospasm, hypotension, or even fatigue, particularly in asthmatic or cardiac-sensitive children. It is also critical to monitor intraocular pressure at follow-up visits and assess adherence, since patients often feel no symptoms despite disease progression. Now taking a closer look at option A, this may sound logical at first, but actually misrepresents how timolol works. Timolol does not improve optic nerve perfusion through local vasoconstriction. In fact, excessive vasoconstriction could compromise blood flow and worsen optic nerve ischemia. The issue in glaucoma is not a lack of perfusion, but rather excessive intraocular pressure, and the role of the medication is to reduce that pressure, not influence circulation. So this explanation falls apart when aligned with the drug's actual pharmacodynamics. Shifting over to option B, this is another tempting but incorrect assumption. The idea that timolol increases tear production confuses its role with that of lubricating agents. Timolol has no action on the lacrimal glands and does not serve to hydrate the cornea. In reality, dry eyes are a reported side effect. It is important that students do not mix up the purpose of comfort measures like artificial tears with the goal of pressure-lowering medications. This option can trip you up if you associate eye drops with comfort rather than therapeutic mechanism. Now zooming in on option D, this one cleverly mimics the language of another treatment class but misattributes it to timolol. Relaxing the ciliary muscle to widen Schlemm's canal is the mechanism of miotic drugs like pilocarpine, which work by facilitating aqueous outflow. Timolol, on the other hand, reduces the inflow, specifically the production of aqueous humor. The distinction between fluid outflow enhancers and production reducers is critical for mastering NCLEX pharmacology, and this distractor is designed to test that exact differentiation. In summary, this question requires students to think like a nurse, match the drug class to its mechanism, connect it to the correct anatomy, and educate the caregiver accurately. Knowing the pathophysiology of glaucoma and the pharmacologic logic of beta blockers like timolol helps ensure safe, effective, and evidence-based nursing care. Here comes a practical scenario focused on proper medication teaching. Question number 11. The nurse is providing home care instructions to the parent of a 7-year-old with acute bacterial conjunctivitis, newly prescribed tubramycin ophthalmic drops. Which statement should the nurse include to promote effective and safe administration? Let us now take a moment to consider each of these responses and identify the one that aligns with safe nursing practice. Option A, stop the drops when redness subsides to avoid over-medicating. Option B, expect the child's vision to become permanently blurry while on this medication. Option C, apply the drops into the lower conjunctival sac without touching the eye. Option D, ask the child to rub the eyelid gently after each dose to help it spread. The correct answer is option C. Apply the drops into the lower conjunctival sac without touching the eye. Now, let us break down why this simple technique makes such a critical difference. Administering eye drops into the lower conjunctival sac is the safest and most effective method, because it allows the medication to evenly coat the surface of the eye without directly irritating the cornea. Pulling down the lower lid creates a small pocket that holds the medication in place, and natural blinking will help distribute it without the need for extra manipulation, emphasizing to caregivers that the dropper should never touch the eye, eyelid, or lashes helps prevent contamination and reduces the risk of introducing new pathogens. It also ensures that the dropper tip stays sterile throughout the course of treatment, protecting both the child and the integrity of the medication. Now, let us look at option A, which may seem harmless but is actually a major teaching error. Stopping the medication early, even when symptoms appear to improve, can lead to incomplete bacterial eradication. This increases the risk for recurrence or even antibiotic resistance, something we want to avoid at all costs. Nurses must clearly explain that completing the full course is necessary, even if the redness and discharge go away within the first couple of days. This promotes full recovery and prevents complications. Shifting over to option B, this statement is not only inaccurate but also fear-inducing. Tobramycin may cause temporary blurriness right after administration, especially with thicker formulations or ointments, but it does not cause permanent vision changes. Telling a caregiver to expect permanent blurriness could create unnecessary worry and lead to poor adherence. Instead, reassure them that any visual disturbance should clear within a few minutes, and if it does not, they should follow up with the healthcare provider. Finally, let us break down option D, which suggests rubbing the eyelid after administration. While it might seem like a way to help the drop spread, this practice can be harmful. Rubbing the eye can introduce new bacteria from the hands, dislodge the medication, or irritate the already inflamed tissue. Nurses should emphasize that blinking is all that is needed to spread the medication, and that children should be gently encouraged not to touch their eyes after receiving drops. So for NCLEX success, always go with the response that reinforces proper administration technique, infection control, and medication adherence, especially when parents are the ones continuing care at home. Let us now focus on antibiotic education, a topic frequently tested on the NCLEX. Question number 12. A nurse is educating the caregiver of a 9-year-old child prescribed oral azithromycin for bilateral otitis media. The caregiver wants to know what side effects they should watch for at home. Which of the following is the most appropriate response? Let us now go through the options and see which response provides the most accurate and helpful guidance. Option A. The most common side effect is gastrointestinal upset, particularly diarrhea. Option B. Be prepared for episodes of confusion and hallucinations as normal reactions. Option C. Expect mild skin bruising and nosebleeds during the course of treatment. Option D. Watch for sudden dizziness and cold extremities as signs of toxicity. The correct answer is option A. The most common side effect is gastrointestinal upset, particularly diarrhea. Now let us understand why this is the most appropriate response. Azithromycin, a widely used macrolide antibiotic, is known for its effectiveness against a range of respiratory, skin, and ear infections, including otitis media in children. However, one of its most frequently reported side effects is gastrointestinal discomfort, especially diarrhea. This occurs due to disruption of normal gut flora, which is a common issue with many broad-spectrum antibiotics. Nurses must inform caregivers that these symptoms are expected and usually resolve on their own. Caregivers should be advised to maintain the child's hydration status, offer small, frequent meals, and administer the medication with food to help reduce gastrointestinal irritation. This education not only promotes adherence, but also prevents premature discontinuation of the antibiotic, which is vital to avoid treatment failure or bacterial resistance. Also, caregivers should be reassured that unless the diarrhea is severe, persistent, or accompanied by blood, it is not a cause for alarm. Now, turning our attention to option B, the suggestion that confusion and hallucinations are normal reactions is both clinically incorrect and potentially dangerous. These are not typical side effects of azithromycin and could be signs of a much more serious issue such as neurotoxicity, severe allergic reaction, or an underlying neurologic disorder. Confusion or hallucinations are red flags that should never be normalized or minimized. NCLEX expects future nurses to differentiate between expected medication effects and symptoms that warrant immediate evaluation. Reinforcing false reassurance can delay appropriate intervention, which may endanger the child's safety. Next, let us evaluate option C, which claims that mild bruising and nosebleeds are expected during treatment. This too is incorrect. Azithromycin does not impair platelet function, bone marrow activity, or coagulation pathways. If these symptoms were to occur, the nurse should consider a more serious etiology, such as a bleeding disorder, thrombocytopenia, or an interaction with another drug like anticoagulants. NCLEX often uses these distractors to test whether you can match side effects to the drug's class and mechanism of action. Teaching caregivers to expect bruising or bleeding as part of normal therapy could desensitize them to serious warning signs that actually need urgent evaluation. Lastly, let us unpack option D, which warns about cold extremities and sudden dizziness as signs of azithromycin toxicity. This is misleading and does not reflect the clinical reality of this medication's safety profile. These symptoms are typically associated with cardiovascular instability, not antibiotic use. While it is true that azithromycin carries a rare risk of QT interval prolongation, particularly in patients with pre-existing cardiac conditions or those on other QT prolonging medications, signs like bradycardia, syncope, or palpitations, not cold limbs, would be more relevant. NCLEX questions like this challenge you to go beyond surface-level symptoms and think critically about what adverse effects are physiologically linked to the drug in question. In summary, when teaching caregivers about azithromycin, the most relevant and useful information includes its common gastrointestinal side effects, the importance of hydration, how to manage mild symptoms at home, and when to report more severe reactions. Mastering this question requires the ability to filter out distractors and align your education with the actual pharmacologic profile of the drug, a skill that will serve you well both on the NCLEX and in practice. Wait a moment before we continue. This could change your entire NCLEX prep. Our complete NCLEX review course includes 100 hours of animated lectures, 500 hours of deep dive teaching, 5,000 powerful practice questions, 500 NGN-style case studies, and 15 full-length exam simulations. You'll also receive a full-access NCLEX ebook for 12 months. The course is now 70% off, but not for long. Tap the link in the description and get started right now. Here comes a question that bridges pharmacology with allergy management. Question num 13. A 12-year-old child with a history of seasonal allergic conjunctivitis is prescribed olopatadine ophthalmic drops. The child's parent asks what benefit the medication will provide. Based on the pharmacologic action of olopatadine, how should the nurse respond? Let us now look at the options to determine which response accurately explains how the medication works. Option A, it stimulates tear production to flush out allergens. Option B, it is an antihistamine that blocks allergic reactions in the eye. Option C, it shrinks blood vessels to improve eye drainage. Option D, it paralyzes ciliary muscles to relax the eye and relieve itching. The correct answer is option B, it is an antihistamine that blocks allergic reactions in the eye. Now here is why this answer is not only correct, but essential knowledge for both NCLEX success and safe patient teaching. Olopatadine is a dual-action ophthalmic medication. It acts as a selective histamine H1 receptor antagonist and as a mast cell stabilizer. This means it blocks histamine already released into the eye, reducing symptoms like redness, itching, tearing, and swelling. At the same time, it prevents mast cells from releasing more histamine when exposed to allergens like pollen, dust, or pet dander. This mechanism makes olopatadine more effective than simple lubricants or vasoconstrictors because it treats both the immediate and long-term allergic response. Nurses must be prepared to explain this to caregivers so they understand that the goal is not instant symptom removal, but overall allergic control over time. Also, reinforcing that this drug is well tolerated for long-term use provides reassurance and promotes adherence. Now let us take a closer look at option A, which states the drops stimulate tear production to flush out allergens. While artificial tears may provide some temporary relief by physically rinsing allergens off the ocular surface, olopatadine is not classified as a tear stimulant or ocular lubricant. It does not work by producing or flushing fluid. Explaining this inaccurately may lead parents to assume it works instantly like saline, when in fact the drug's strength is its ability to block allergic inflammation from the inside out. Educating properly helps caregivers understand the difference between comfort-based therapies and pharmacologic ones that address the root cause. Now zooming in on option C, we see another commonly confused concept. Vasoconstriction does reduce eye redness, and some over-the-counter eye drops use this approach, such as tetrahydrozoline. However, olopatadine does not cause vasoconstriction. It does not act on blood vessels, but instead targets histamine receptors and mast cells. Telling caregivers that olopatadine shrinks blood vessels may make them expect immediate whitening of the eyes, which could create disappointment or misuse of the medication. It is essential to distinguish drugs that address redness symptomatically from those that treat the underlying cause. Finally, let us break down option D, which suggests that olopatadine works by paralyzing the ciliary muscles to relieve itching. This describes the mechanism of cycloplegic agents like atropine and cyclopentolate, which are used during eye exams or for certain inflammatory conditions. Those drugs relax the eye's focusing muscle to reduce pain or improve diagnostic clarity, but have nothing to do with histamine or allergies. Using this explanation would confuse caregivers, especially if they worry that the medication will affect the child's vision or ability to focus, when in fact, olopatadine does not alter the ciliary muscle at all. Nurses must be precise when teaching medication actions, especially when multiple eye drops have different mechanisms. For NCLEX mastery, remember that allergic conjunctivitis is treated most effectively with medications that block histamine activity and stabilize mast cells, and that olopatadine is a prime example of this class. Knowing how to explain the difference between mechanism, symptom relief, and expected results will not only help you answer questions correctly, but will also improve your patient teaching and real-world practice. Let us now shift into a common pediatric situation. Question number 14. A 5-year-old child is diagnosed with acute otitis media with effusion and is prescribed oral acetaminophen for symptom control. The caregiver is concerned about giving medication for ear pain. What should the nurse include in education regarding the role of acetaminophen? Let us examine each response carefully to identify which one reflects accurate, clinically sound teaching. Option A. It reduces inflammation of the eustachian tube to help drain fluid. Option B. It works centrally to relieve pain and reduce fever without treating the infection. Option C. It clears up the infection by eliminating bacteria from the middle ear. Option D. It improves hearing by thinning out middle ear fluid. The correct answer is option B. It works centrally to relieve pain and reduce fever without treating the infection. And here is why this explanation is not only correct, but essential for setting proper expectations with caregivers. Acetaminophen, also known as paracetamol, exerts its effect primarily by acting on the hypothalamic heat-regulating center to lower body temperature, and it alters the perception of pain at the central level, within the brain, not at the site of inflammation. This makes it highly effective for controlling symptoms like ear pain and fever, both of which are common in acute otitis media. However, it is critical to explain that this medication does not eliminate the underlying infection or reduce the fluid buildup directly. Instead, its role is to keep the child comfortable, promote hydration, encourage rest, and reduce the likelihood of complications like febrile seizures. Nurses must teach caregivers that symptom control is a key component of care, especially in viral or mild cases where antibiotics are not immediately indicated, and that when used correctly, acetaminophen is both safe and helpful. Now, breaking down option A, this one contains a common misunderstanding. While it is true that swelling and blockage of the eustachian tube contribute to middle ear effusion, acetaminophen is not an anti-inflammatory agent. It does not reduce swelling or promote drainage the way non-steroidal anti-inflammatory drugs like ibuprofen might. Even then, mechanical obstruction of the tube is not resolved pharmacologically in most cases. It resolves naturally over time. Teaching that acetaminophen will drain fluid is inaccurate and could lead caregivers to expect rapid resolution of ear fullness or hearing changes, which are typically slow to improve. Now let us look at option C, which incorrectly states that acetaminophen clears up infection. This is a critical point to clarify in both nursing education and caregiver instruction. Acetaminophen has no antimicrobial or bactericidal properties. It cannot kill bacteria or treat the infection itself. That role belongs to antibiotics, and even then, not all children with otitis media require immediate antibiotic treatment, depending on clinical guidelines. Emphasizing that acetaminophen is part of supportive care, not curative care, helps caregivers understand the importance of completing full treatment plans and knowing when to return for follow-up. Finally, consider option D, which claims that acetaminophen thins out middle ear fluid to improve hearing. This is incorrect. Acetaminophen has no effect on fluid viscosity or inner ear pressure and does not influence hearing function in this context. Hearing loss in otitis media with effusion is usually temporary and due to the fluid dampening the vibration of the tympanic membrane. As the effusion resolves, whether naturally or with tympanostomy tubes, hearing gradually returns to normal. Nurses must help families understand that medication will ease the child's discomfort but not directly restore hearing. For NCLEX success and real-world readiness, students must differentiate between symptomatic relief and disease-specific treatment. Acetaminophen is a cornerstone in pediatric care for pain and fever, and knowing how it works, and just as importantly, how it does not, empowers both the nurse and the caregiver to make informed, safe decisions. Now, let us move into the realm of surgical follow-up care. Question number 15. A 7-year-old child with chronic bilateral serous otitis media is scheduled for tympanostomy tube insertion. Post-operatively, the surgeon prescribes ofloxacin otic drops. What is the primary rationale for this prescription in the post-operative period? Let us review each of the answer choices to determine which aligns with evidence-based nursing knowledge. Option A. It lubricates the ear canal to prevent dryness and itching. Option B. It prevents fungal colonization in the ear canal during healing. Option C. It reduces the risk of bacterial infection following tube placement. Option D. It numbs the tympanic membrane to prevent post-operative discomfort. The correct answer is option C. It reduces the risk of bacterial infection following tube placement. Now here is why this answer is not just correct. It is a critical component of post-operative pediatric care. Ofloxacin is a fluoroquinolone antibiotic specifically formulated for otic use, and it is particularly valuable after tympanostomy tube placement because it offers strong bacterial coverage, excellent middle ear penetration, and a low risk of ototoxicity. The presence of a newly inserted tube creates a direct pathway between the external auditory canal and the middle ear, increasing the risk of bacterial contamination, especially if water, secretions, or external particles enter the canal. By prescribing ofloxacin immediately after surgery, clinicians aim to prevent early postoperative otorrhea or middle ear infection, which can compromise healing or lead to tube extrusion. Nurses play a vital role in teaching caregivers that the antibiotic is preventive, not for pain relief or moisturizing, and that correct administration is essential for protecting surgical outcomes. Now, let us look more closely at option A, which inaccurately describes ofloxacin as a lubricant. This is a clear misrepresentation of its pharmacologic class. Ofloxacin does not contain any moisturizing or emollient agents and has no role in addressing dryness or itching of the ear canal. In fact, postoperative dryness is not a standard concern after tympanostomy placement. Nurses should avoid creating confusion by attributing moisturizing properties to an antibiotic. This kind of misinformation can cause caregivers to misunderstand both the function and necessity of the prescription. Turning to option B, this answer wrongly claims that ofloxacin prevents fungal infections. While fungal infections of the external ear canal, known as otomycosis, do occur, they are typically not a post-operative concern after tympanostomy tube placement. Moreover, ofloxacin is a broad-spectrum antibiotic, not an antifungal. Fungal infections are treated with specific antifungal agents, such as clotrimazole or acetic acid formulations. Teaching caregivers that their child is receiving antifungal protection with ofloxacin is incorrect and might cause them to overlook true signs of fungal involvement in the future. Now considering option D, this choice incorrectly presents ofloxacin as an anesthetic. While it may help reduce local inflammation associated with minor infection or irritation, it has no direct numbing or analgesic effects. It does not act on nerve endings the way topical anesthetics like benzocaine or systemic medications like acetaminophen do. Nurses should clarify this distinction, especially if caregivers are expecting the drops to relieve pain. Post-operative discomfort from tympanostomy is typically mild and managed with oral analgesics. So it is important to manage expectations about what the antibiotic can and cannot do. For NCLEX success, remember this critical teaching point. Ofloxacin is prescribed post-tympanostomy, not for comfort, not for moisture, and not for fungal prevention. It is to reduce the risk of bacterial infection through a surgically altered pathway. Nurses must ensure parents understand the rationale, administration technique, and need for follow-up so that the child's hearing and surgical outcomes are protected. Here comes a question that highlights the importance of understanding drug-nutrient interactions. Question number 16. A 6-year-old child with a recent diagnosis of bacterial otitis media is prescribed oral cefdinir. The parent later reports that the child's stool appears reddish after taking the medication with iron-fortified formula. What should the nurse explain about this finding? Let us explore each of the choices and determine which one provides an accurate and clinically sound explanation. Option A. This indicates gastrointestinal bleeding and requires emergency evaluation. Option B. The drug has interacted with iron, causing a harmless red discoloration of the stool. Option C. This suggests hepatic toxicity and the drug should be discontinued immediately. Option D. This is a common sign of antibiotic-induced colitis. The correct answer is Option B. The drug has interacted with iron, causing a harmless red discoloration of the stool. And here is why this information is vital to communicate during nursing education. Cefdinir, a third-generation cephalosporin commonly used to treat ear infections in children, is known to bind with iron in the gastrointestinal tract. When cefdinir interacts with iron, either from supplements or from iron-fortified infant formulas, it forms a non-absorbable complex that can appear reddish or orange in the stool. This is a documented, benign, and purely cosmetic effect. It does not indicate bleeding, infection, or treatment failure, and it does not impair the absorption or effectiveness of the antibiotic. Nurses should be proactive in informing caregivers of this potential side effect before it causes alarm. Letting parents know that this discoloration is expected and harmless increases trust and prevents unnecessary visits or early discontinuation of therapy. Now, let us unpack Option A, which raises concern for gastrointestinal bleeding. While it is always important to evaluate symptoms like blood in the stool, true gastrointestinal bleeding presents very differently. Upper gastrointestinal bleeding typically results in black, tarry stools, known as melena, while lower gastrointestinal bleeding may produce bright red blood, often streaked on the surface of the stool. Neither of these presentations is described here. There is no mention of abdominal pain, hemodynamic instability, fatigue, or signs of anemia. Educating caregivers that not all red-colored stool is dangerous prevents undue panic and fosters better clinical judgment. Now turning to Option C, this incorrectly links red stool to hepatic toxicity. Hepatotoxicity would present with very different signs, most notably jaundice, dark urine, pale stools, right upper quadrant pain, and possibly changes in mental status due to hepatic encephalopathy. Red stool is not a typical or expected sign of liver damage. Nurses must know and teach the true clinical indicators of hepatotoxicity rather than associating unrelated findings with serious adverse effects. Let us now examine Option D, which refers to antibiotic-induced colitis. This condition, more formally known as Clostridioides difficile-associated diarrhea, generally presents with profuse watery diarrhea, abdominal cramping, fever, and sometimes leukocytosis. It is a serious complication, but relatively rare in children receiving short, uncomplicated courses of antibiotics like cefdinir. Red discoloration of the stool, in the absence of diarrhea or pain, does not fit the picture and should not be attributed to colitis. Mistaking harmless stool changes for signs of infection or inflammation can lead to confusion and mismanagement. For NCLEX preparation and real-world practice, this question is a perfect example of why nurses must not only know drug actions, but also anticipate and explain side effects, especially those that look alarming but are completely benign. A calm, confident explanation supported by pharmacologic knowledge builds caregiver trust and ensures that safe, effective treatment continues without unnecessary interruptions. Time for another shot at NCLEX success. Here's question number 17. The nurse is reviewing medications for a 3-year-old child with a history of sensorineural hearing loss. Which prescribed drug should prompt the nurse to notify the provider due to its known ototoxic potential? Let us walk through each option and evaluate which one raises the greatest concern for a child with impaired hearing. Option A, loratadine. Option B, acetaminophen. Option C, gentamicin. Option D, amoxicillin clavulinate. The correct answer is Option C, gentamicin. Now, let us explore why this medication demands caution and immediate nursing intervention. Gentamicin belongs to the aminoglycoside class of antibiotics, which are well documented for their potential to cause ototoxicity, meaning damage to the structures of the inner ear, particularly the cochlea and vestibular apparatus. This risk is especially concerning in children who already have sensorineural hearing loss, as any additional injury to the auditory system could result in irreversible worsening of their condition. Ototoxicity from gentamicin is often dose-related and may occur even when serum levels are within therapeutic range, particularly with prolonged therapy or in the presence of renal impairment. It can manifest as hearing loss, tinnitus, or balance disturbances. For this reason, its use in children with existing hearing deficits should be limited to situations where no safer alternatives exist, and always under close monitoring, including baseline and follow-up audiologic assessments and renal function tests. Nurses must recognize this as a high-priority safety issue and advocate for the child by promptly alerting the provider. Now examining option A, loratadine is a second-generation antihistamine that is commonly prescribed for allergic rhinitis and other mild allergic conditions. It is considered very safe for pediatric use and is not associated with ototoxicity. Unlike older first-generation antihistamines, loratadine has minimal sedative effects and does not impact hearing or balance. It can be safely given even to children with auditory impairments, making it a non-issue in this scenario. The NCLEX often uses safe medications as distractors, so it is essential to distinguish low-risk drugs from those that require close observation. Let us now turn to option B, acetaminophen. This widely used antipyretic and analgesic is a staple in pediatric medication regimens. It works centrally to relieve pain and reduce fever, but has no known effects on auditory structures. While liver toxicity can occur if the dosage exceeds recommended limits, particularly in chronic or accidental overdose situations, hearing loss is not among its side effects. It remains safe to use in children with hearing impairments as long as dosing guidelines are strictly followed. Nurses must be able to separate systemic organ concerns, like hepatic injury, from sensory risks, like ototoxicity, and acetaminophen does not fall into the latter category. Finally, we come to option D, amoxicillin clavulanate. This broad-spectrum penicillin-based antibiotic is commonly prescribed for upper respiratory infections, sinusitis, and otitis media. It has no ototoxic potential and is frequently used even in children with ear disorders. Its most common side effects are gastrointestinal, such as diarrhea or mild nausea, but it does not pose a risk to auditory or vestibular structures. In fact, it is often used to treat infections that, if left untreated, could contribute to conductive hearing issues, making it beneficial rather than harmful in children with hearing concerns. For NCLEX success, this question underscores the importance of knowing not just how drugs work, but also who they are safe for. Aminoglycosides like gentamicin are classic high-alert medications in pediatrics due to their irreversible impact on hearing. Nurses must be vigilant in screening for pre-existing conditions like sensorineural hearing loss and understand when a provider should be notified to reassess the treatment plan. Recognizing and preventing medication-related harm is at the heart of nursing safety. Let us turn our attention to a medication error scenario that highlights the dangers of incorrect drug routes in pediatric care. Question 18. A 4-year-old child being treated for conjunctivitis is mistakenly administered a systemic dose of neomycin instead of topical neomycin polymyxin drops. Which of the following complications is the nurse most concerned about monitoring? Let's go through the answer choices like a nurse would. A. Renal toxicity and hearing loss due to systemic aminoglycoside exposure. B. Liver failure due to hepatic metabolism overload. C. Hypoglycemia due to altered pancreatic insulin secretion. D. Visual hallucinations due to central nervous system toxicity. The correct answer is option A, renal toxicity and hearing loss due to systemic aminoglycoside exposure, and here is why this is a top priority concern in nursing safety. Now, let us focus on what makes this the correct choice. Neomycin is an aminoglycoside antibiotic, and when administered systemically, especially in error, it poses a significant risk for nephrotoxicity and ototoxicity. These effects are well documented and particularly worrisome in children whose renal systems are not fully matured. Systemic absorption can impair renal tubule function and accumulate in the inner ear, leading to irreversible damage to the cochlear and vestibular systems. The nurse's primary responsibility here is to notify the provider immediately and begin monitoring renal function through serum creatinine and urine output, while also assessing for any signs of hearing changes, such as tinnitus, balance disturbances, or difficulty responding to sounds. This scenario also reinforces the importance of verifying formulation and route, as many topical medications have systemic counterparts with vastly different safety profiles. The NCLEX often tests on medication safety and error prevention, and this question underscores the need for vigilance. Now, moving to option B, liver failure due to hepatic metabolism overload is an unlikely concern here. Neomycin is minimally absorbed through the gastrointestinal tract and does not undergo significant hepatic metabolism. When toxicity occurs, it is almost always renal or auditory, not hepatic. Liver failure typically arises from drugs like acetaminophen, certain antifungals, or chemotherapeutic agents, not aminoglycosides. Educating students on the difference between hepatotoxic and nephrotoxic drugs is key to passing NCLEX pharmacology sections. Shifting to option C, hypoglycemia, due to altered insulin secretion is not a known effect of neomycin. This complication is far more likely with antidiabetic medications such as insulin or sulfonylureas. Introducing this as a distractor serves to test pharmacologic awareness, but it is a red herring here. In pediatric pharmacology, always link drug classes to their systemic effects accurately. Aminoglycosides do not influence glucose regulation. Lastly, let us clarify option D, which mentions visual hallucinations due to central nervous system toxicity. While some antibiotics, such as high-dose penicillins or fluoroquinolones, have been associated with neurotoxicity, neomycin does not readily cross the blood-brain barrier in therapeutic doses and is not linked to hallucinations. This distractor is meant to challenge your understanding of drug penetration and side effect profiles, and again reinforces that the most critical toxicities for neomycin are renal and auditory. One important clinical insight to remember is that systemic aminoglycosides like neomycin, gentamicin, and tobramycin are powerful but carry high risk. Nurses should always double-check the route and formulation, especially with medications that come in both topical and systemic versions. It is critical to monitor for changes in hearing, balance, urine output, and lab values like serum creatinine. Most importantly, in the event of a medication error, early recognition and prompt intervention can prevent long-term harm. This kind of clinical judgment and pharmacologic vigilance is exactly what the NCLEX exam is designed to assess. So make sure it becomes second nature. Let's pause for a second. Are you ready to take the NCLEX with confidence? If not, don't worry. The complete NCLEX review course has 100 animated hours, 500 recorded hours, 5,000 high-yield practice questions, 500 NGN case studies, and 15 mock exams built to mirror the real test. You also get a 1-year ebook. Enroll now and get 70% off. Limited time offer. The link is right in the description. Let us now shift our focus to discharge education with question number 19. A nurse is reviewing discharge medications with the caregiver of a child treated for otitis externa. The prescription includes ciprofloxacin hydrocortisone eardrops. What key teaching point should the nurse emphasize regarding the corticosteroid component? Now it is your turn. Look at the options and start thinking. A. It acts as an anesthetic to numb the ear and reduce pain. B. It reduces inflammation and edema in the external auditory canal. C. It stimulates immune cell migration to the infection site. D. It enhances the antibiotic's bactericidal effect through synergy. The correct answer is option B. It reduces inflammation and edema in the external auditory canal, and let us walk through exactly why that is the most appropriate and NCLEX-relevant teaching point. Corticosteroids like hydrocortisone are not antibiotics or anesthetics. They are anti-inflammatory agents. In the context of otitis externa, the inflammation in the ear canal can cause swelling that traps bacteria, causes pain, and blocks drainage. Hydrocortisone works by suppressing inflammatory mediators, reducing vascular permeability, and relieving swelling. This leads to improved comfort and facilitates better penetration of the antibiotic to the site of infection. Explaining this clearly to the caregiver ensures they understand that the steroid is reducing pressure and pain not by numbing, but by calming the immune response. This is a powerful pharmacologic principle that NCLEX questions love to explore. How two drug components work together but differently. Now for option A, this is a common misconception among caregivers, and sometimes even new nurses. Corticosteroids are not anesthetics. While they may relieve pain indirectly by reducing swelling, they do not block nerve signals or provide immediate numbing. That job belongs to drugs like lidocaine. Mislabeling corticosteroids this way could delay or prevent appropriate use of analgesics if needed, and falsely inflate caregiver expectations of how fast the medication will work. Turning our attention to option C, this choice reflects a misunderstanding of corticosteroid pharmacodynamics. Hydrocortisone and other steroids suppress the immune response. They reduce cytokine release, inhibit leukocyte migration, and lower the overall inflammatory reaction. While that is beneficial in localized inflammation like otitis externa, it is why steroids are contraindicated in uncontrolled systemic infections. Nurses must teach that the steroid does not boost immune activity. It actually tones it down to ease symptoms. Now let us dissect option D, which suggests synergy in bacterial killing between ciprofloxacin and hydrocortisone. This is another tempting but inaccurate answer. There is no chemical or pharmacodynamic synergy between these two drugs. Ciprofloxacin kills bacteria by interfering with DNA gyrase, while hydrocortisone modulates the immune response. The steroid helps the drops get deeper into the canal and reduces the tissue response, but it does not increase the bactericidal power of the antibiotic. They are complementary in function but do not act synergistically in the strict pharmacological sense. When educating families, nurses should emphasize that ciprofloxacin hydrocortisone ear drops serve a dual purpose. One part fights infection, and the other reduces swelling and pressure. The nurse should also instruct caregivers to keep the ear canal dry, avoid swimming during treatment, and warm the drops in their hands before administering them to prevent dizziness. Reinforce the importance of completing the full course, even if symptoms improve quickly. These are essential points that can make a huge difference in recovery, and are exactly the kind of high-yield insights that show up on NCLEX exams. You have made it this far. Let's tackle the last challenge with question number 20. A 2-year-old child with frequent ear infections is placed on prophylactic low-dose amoxicillin. The parent expresses concern about antibiotic overuse. Which explanation by the nurse best addresses this concern? Let us examine the answer choices and determine which response reflects both scientific accuracy and patient-centered education. Option A. This dose prevents future infections by fully eradicating all bacteria from the middle ear. Option B. Prophylactic amoxicillin may reduce infection frequency in high-risk children, but should be used short-term only. Option C. This medication stimulates immune development in children prone to ear infections. Option D. Low-dose antibiotics do not impact resistance, so it is safe for long-term use. The correct answer is option B. Prophylactic amoxicillin may reduce infection frequency in high-risk children, but should be used short-term only. Now, here is why this explanation is both clinically accurate and a responsible approach to parental concern. Children under 2 years of age who experience recurrent otitis media, typically defined as 3 or more infections within 6 months or 4 within a year, may be considered candidates for short-term prophylactic antibiotic use. The rationale behind this approach is to decrease the frequency and severity of infections while allowing the eustachian tubes and immune system to mature naturally. Amoxicillin, in low doses, helps suppress pathogenic bacteria without completely sterilizing the ear or eliminating the normal flora. It is important that nurses educate parents that this is a temporary strategy, not a permanent fix, and that its use should be reassessed every few months. The ultimate goal is to either taper off the antibiotic as infections subside or move toward a surgical intervention, like tympanostomy tubes, if infections continue. This kind of teaching provides balanced, evidence-informed reassurance while also honoring the caregiver's concern about antibiotic exposure. Now, let us turn to option A, which incorrectly claims that low-dose prophylactic amoxicillin eradicates all bacteria from the middle ear. This is an oversimplification and clinically misleading. The goal of prophylaxis is not to sterilize the ear, but to lower bacterial load and prevent inflammation that triggers symptoms. It is essential for nurses to explain that bacterial colonization is often present even in healthy children, and that complete eradication is neither achievable nor necessary for clinical improvement. Promising eradication sets caregivers up for disappointment and may lead to distrust when infections recur despite prophylaxis. Next, examining option C, the claim that amoxicillin stimulates immune development is scientifically inaccurate. Antibiotics do not enhance immune function. They target bacterial cell wall synthesis to suppress or kill susceptible organisms. In fact, overuse of antibiotics can sometimes impair normal immune balance by disrupting the child's microbiota, potentially making them more vulnerable to certain infections. Teaching that antibiotics build immunity may cause parents to expect long-term health benefits that are not pharmacologically supported and could increase pressure to continue unnecessary medication. Now, looking at option D, this statement dangerously downplays the reality of antibiotic resistance. Even at low doses, antibiotics exert selective pressure on microbial populations, potentially encouraging the growth of resistant strains. The NCLEX emphasizes that all antibiotic use should follow principles of stewardship, prescribing only when necessary, using the narrowest effective agent, and reviewing the need for continuation at regular intervals. Telling caregivers that low-dose antibiotics do not carry resistance risks could lead to misuse, misinformed consent, and long-term harm at the community level. For NCLEX mastery and real-world practice, nurses must be able to confidently explain both the benefits and limitations of prophylactic antibiotic therapy. In doing so, they support informed parental decision-making, promote safe and responsible use of medication, and reinforce trust in the healthcare team, all while protecting individual and public health through antibiotic stewardship. You have just finished mastering the essentials of pharmacology in child health, visual and auditory systems. We hope it helped you feel more confident about these high-yield NCLEX topics. We will be back with another powerful video very soon, so keep watching and stay consistent with your prep. Remember, we cover essential NCLEX concepts and questions every single day, focusing on exactly what you need to know to pass the exam. So do not miss out. Make sure to watch our videos regularly and follow us for daily updates that keep you on track and ahead in your NCLEX journey.